Let's dive right into this explainer. Today, we're tracking the journey of a single breath, going all the way from the atmosphere outside down into the microscopic alveoli of the lungs. We breathe something like 20,000 times a day without even thinking about it, but the physics governing how that gas actually travels, mixes, and diffuses into our bloodstream, it is an absolute engineering marvel. So let's make this highly visual and map out exactly how this invisible transport system works. To kick things off, consider this physiological paradox. How does a newborn infant, or say a panting dog, successfully exchange gas when their tiny, rapid breaths don't even seem large enough to clear their own anatomic dead space? Think about it. If a breath is actually shallower than the airway tube itself, how on earth does fresh oxygen ever reach the deep lungs? Keep that little mystery in the back of your mind because the answer totally defies our everyday logic of how air is supposed to move. To solve this, we're going to break this down into 5 short, easy-to-remember areas: normal breathing, positive pressure, understanding dead space, the weird physics of panting, and finally, gas diffusion. Section 1. How we normally breathe, relying on the power of negative pressure. So, spontaneous breathing relies entirely on creating a negative pressure gradient. It's all about the active contraction of the respiratory muscles. As the diaphragm descends, it's literally creating a vacuum. The intrapleural pressure drops and becomes significantly more negative than the atmospheric pressure at the mouth. And since gas naturally wants to flow down a pressure gradient, this negative pressure actively pulls that fresh air through the airways and deep into the lungs. Moving right along to Section 2, positive pressure ventilation, and how we change that gradient. Now, what happens when a patient just can't create that pull themselves? Well, we have to intervene, and when we do, the physics fundamentally flip. This contrast is absolutely crucial to understand. While normal spontaneous breathing pulls air in using negative pressure, mechanical ventilation forces gas down the airway using a positive pressure gradient. We're no longer pulling, we are pushing. The pressure at the upper airway is artificially cranked up, so it's greater than both atmospheric and alveolar pressure. But creating that artificial push has some serious downstream effects. That positive pressure inside the chest cavity does a lot more than just inflate the lungs. It physically presses against the surrounding structures, which inevitably impedes venous blood return to the heart. Because of this, a life-saving mechanical breath can actually end up dropping the patient's cardiac output. It is a really delicate balancing act. To help manage that balance, we use a simple metric called the minute ventilation equation. It's a great short note to jot down. VE equals VT times F. Basically, your minute ventilation is just your tidal volume, the size of a single breath, multiplied by your respiratory frequency, or your breaths per minute. It gives us the total bulk amount of gas moving in a given minute. Okay, Section 3, understanding dead space, or what we call wasted ventilation. Here's the catch. Not all of that inspired gas actually participates in keeping the patient alive. A pretty significant chunk of your tidal volume just sits there stuck in the conducting airways, like the trachea and bronchi. No gas exchange happens there at all, which is why we call it anatomic dead space. Because of this, rapid, shallow breathing is incredibly inefficient. It creates a massive dead space to tidal volume ratio. If your breath is tiny, almost the entire breath is just filling that dead space tube. It's completely wasted ventilation. Which brings us to Section 4, the weird physics of panting and high-frequency flow. So, back to our paradox. If shallow breathing is so inefficient, how do infants or patients on high-frequency ventilators survive? The secret is something called the spike theory. When air moves at super high speeds, it stops acting like a solid block. Instead, these low-volume pulses shoot straight down the absolute center of the airway like rapid-fire spikes. The faster and more energetic the puff, the sharper the spike. This dynamic mechanism allows a tiny puff of air to pierce right through the dead space and penetrate way deeper into the lungs than the tidal volume math would suggest. To easily understand this, let's visualize it as a 3-step dynamic infographic. Under high-frequency ventilation, gas transport literally skips normal bulk flow and relies on these wild, almost quantum-like physical mechanisms. Step 1 is axial convection, those central spikes we just mentioned. Step 2 is radial mixing, where the gases diffuse outward toward the edges of the airway. And Step 3 is viscous shear, where different layers of gas physically slide past each other at totally different speeds. The real magic here is in the velocity. Gas in the dead center of the airway faces way less frictional resistance from the walls, right? So it travels faster and farther than the gas out near the edges. This creates a really cool cone-shaped front during inspiration. Then, when the patient exhales, the velocity changes again, creating this chaotic but highly efficient interface where fresh oxygen slides right past the outgoing carbon dioxide.
And it gets weirder. Because during this high-velocity flow, not all parts of the lung fill up at the same speed. The lung is actually divided into fast units with low resistance and slow units that take a little longer to fill. During high-frequency ventilation, the fast units inflate quickly and then rapidly deflate. But as they deflate, they literally exhale their gas directly into the neighboring slow units that are still trying to expand.
We call this internal gas pedaling, Pendeluft, which is German for pendulum air. It is wildly counterintuitive, but this constant back and forth shuffling of gas between different lung units actually improves overall gas mixing. The lungs are literally sharing air internally, even when the net movement of air at the mouth is zero. How cool is that?
Finally, we reach section 5, the rules of gas diffusion and crossing the membrane. Once the gas navigates all those central spikes and the Pendeluft, it has one last hurdle, actually crossing the microscopic membrane into the blood. This is governed by Fick's equation. For your short notes, just remember diffusion relies on the area available, the concentration difference, and critically, the distance the gas has to travel. That's dl. This perfectly explains why something like pulmonary edema is so dangerous. Edema adds fluid, which increases that diffusion pathway length. And when that pathway gets longer, it severely kills your ability to get oxygen in and CO2 out, no matter how perfectly the ventilator is running. So mapping out how a breath truly journeys into the lungs, from the simple pull of a diaphragm all the way down to the mind-bending physics of axial spikes and Pendeluft, leaves us with a massive realization. These airways are not just simple static pipes. They are dynamic, incredibly complex highways. And it leaves us with this final question to ponder. By visualizing and mastering these invisible laws of gas transport, how much better can we engineer the life-saving therapies of tomorrow for our most vulnerable patients? Thanks for joining me on this explainer, and keep questioning how the invisible world works.